everyone, and welcome to this psoriasis awareness session. I'm Dr. Anisha Amlani from Integrated Health and Wellbeing Council. Today, we'll be talking to one of the top dermatologists from India, Dr. S G Parasramani, a consultant at Anisha Clinic. We'll be talking about psoriasis awareness. Psoriasis, a disease that isn't just skin deep, a disease that affects approximately 10 million people in India. This disease is not fully understood, and with the launch of Live Life Limitless, an awareness program, we aim to make an impact on the awareness of psoriasis, right from the basics, do's and don'ts, to the advancement in therapies. As you begin, my first question to Dr. Parasramani is, Sir, what is psoriasis? And if you could help us understand the impact it has on patients' life.
Good morning to everybody. Now, psoriasis is a patellosquamous skin disorder. Basically, this occurs in those who are genetically predisposed. And this is around 2% of the world population, those who are prone to psoriasis. And so about 125 million people in the world are affected with psoriasis, and 20% of this population is in our country. And apart from being genetically predisposed, there are certain aggravating factors which come into play, then which starts the immunological process. And once the immunological process starts, these patients tend to develop patches on their body. Now, psoriasis can be of different forms. It may only involve the scalp, which is known as scalp psoriasis. It may involve only palms and toes, which is known as palmoplantar psoriasis. Then it can involve the whole body when it is known as a generalized plaque psoriasis. Similarly, it can involve the body folds when it is known as intertriginous psoriasis. Apart from this, patients may sometimes, uh, and especially children, following an infection, they can develop psoriasis, which is known as backache psoriasis. And at times only nails are involved. So, and then some patients get pustular lesions, they are known as pustular psoriasis, which can again be localized form and a generalized form. And apart from psoriasis, which may be associated joint involvement be there, which is quite difficult for the patient. When the joints are involved, 30% of the patients with psoriasis can develop joint involvement, which is known as psoriatic arthritis. And this is very, very painful, and many of the patients can get joint involvement after few years of getting psoriasis. And few patients, it may just start immediately along with psoriasis, and there may be a small subset of patients who have only psoriatic arthritis without skin involvement, where it becomes very difficult to treat. There are certain parameters. If you use that, then you can definitely diagnose. So diagnosis may become difficult in patients who have got no skin lesions and only involvement of joints. And in psoriasis, they tend to develop erythematous uh, lesions which are covered with silvery white scales. And once the scales are removed, then you can see bleeding points, which is known as Auspitz sign. Even without doing a biopsy or any other dermatoscopic examination, we can diagnose psoriasis. It becomes that easy when you elicit the Auspitz sign.
Sure. Thank you, sir. So our next question is, what are the chronicity of psoriasis and what are the long-term complications?
Psoriasis being an autoimmune disease, when a person gets psoriasis, then psoriasis is going to remain lifelong. They may go into remission, natural remission intermittently on their own, but it is not the drug which has got rid of the disease. So there is no cure of psoriasis, but definitely we have a good control of psoriasis. We have got very good medications now, which we will be discussing later, and these medications can control the psoriasis and give the patient almost 100% normal life.
So what are the treatment options available for patients in terms of conventional, topical, and other treatment options?
Depending on the extent of psoriasis, we classify psoriasis into mild, moderate, and severe. Mild is when they've got involvement of 5% of the body surface area, or the PASI is low, less than 5. In these patients, we can use topical therapies in the form of emollients, topical corticosteroids, topical calcineurin inhibitors, topical vitamin D3 analogs. So these are the various combinations can be used, and these are applied on the psoriatic lesions and try to bring it under control. In some patients, we can even use phototherapy. We have a narrow band UVB therapy, which is very safe. Even PUA therapy can also be used in patients who have got little extensive lesions. When patients have got psoriasis, which is moderate, more than 5% of the body surface area, moderate to severe, severe will be beyond 10 to 15. So if they're in the moderate stage, then we can use topicals. Along with this, we can start conventional systemic therapy. Conventional systemic therapy consists of, well, if you want something to, some drugs to control the disease very fast, then we can use cyclosporin, which is a crisis buster of a drug. When given, it can control the disease very fast. So, but unfortunately, we cannot use this drug for a long time. We can give for 4 5 months, but not more than 1 year. So we try to restrict this drug only uh, during the time of emergency. Then there are other drugs that we can use as methotrexate, which is a time-honored drug which is being used for last many years. I would say 4 5 decades we have been using, or even longer we have been using methotrexate. But methotrexate does have its end organ toxicity. That there can be hematological toxicity, involvement of the liver, involvement of kidney. So these are problems which are associated with methotrexate. Again, those who are trying to conceive or get pregnant, and then those who are lactating mothers, of course, methotrexate can be used. In the very elderly, we can use with great care. If there's underlying comorbidities, then methotrexate we may not be able to use. Then we have acetaten. It's not a very good drug, but we can use that drug. But then acetaten cannot be given to women of childbearing age, because if they are on acetaten, at least for 2 years they can't conceive, till the complete washout of the drug occurs. So acetaten is contraindicated in women of childbearing age. And then acetaten in elderly, there's a problem because it can increase the lipids, and then they can develop dyslipidemia. So this is where there's a problem with this drug. Then we have got Ipramelas. It's a drug. Some people respond, some people don't respond, and it may work for only certain phenotypes of psoriasis, like palmoplantar psoriasis or scalp psoriasis. It will not work for arthritis. It will not work for extensive psoriasis. And there are certain side effects associated with Ipramelas. Then off-label use of tofacitinib is there. But then that's also not a very great drug. Some people respond and some people don't respond. So this in term are this is the list of conventional systemic drugs which we have in India. Fumarates are available abroad. We don't have them in our country. Then apart from this, we can use biologics to our patients, which are wonderful drugs that can be given to patients to control their disease, especially those who have moderate to severe psoriasis.
So, since you've mentioned biologics, could you elaborate on biologics and why biologics help live life limitless?
See, biologics are wonderful drugs, and they have come to us almost 30 years ago. And we started with antibiotics, which was the first drug. After that, the other TNF alpha inhibitors came. That was etanercept, adalimumab, then infliximab came little earlier before adalimumab. Then Sartozizumab and Golimumab. These are the TNF alpha inhibitors. But Golimumab can only be used for psoriatic arthritis. It's not a good drug for psoriasis. Sartozizumab, a TNF alpha inhibitor, is a good drug, and this does control psoriasis. And the advantage of this drug is it can be given to pregnant females because it is a large molecule, and the molecule does not cross the placenta. As a result of it, the child will not be affected. So this drug can be given to pregnant people. That is one. And then apart from this, then came the IL-12/23 inhibitor, setinumab, which blocks IL-12 and IL-23 receptors, so that we find that IL-12 and IL-23 cytokines are not released, and thereby psoriasis can be controlled. But this is again a good drug to treat psoriasis, but not an excellent drug for psoriatic arthritis. Whereas the TNF alpha inhibitor can be used for psoriasis and psoriatic arthritis. And after this came IL-17 inhibitor. IL-17 inhibitors have come around 2012 and 13. In India, it came in 2015. We have got secukinumab and secukinumab. Both of these drugs are available in our country, and secukinumab is there abroad, which is again doing quite well. So these are IL-17 inhibitors which are available. And then we have got IL 23 inhibitors. None of them have come to India, but we are really game changer. And these are Rizarumab, Secukinumab, and Utensilumab. The advantage with IL-23 inhibitors is that you can give this drug once in every 3 months or once in every 2 months, depending on the drug that you are using. Guselkumab can be given once in every 2 months, and Utensilumab and Rizarumab once in every 3 months, which means they can take only 4 injections in a year, and the psoriasis is controlled in a very big way. With biologics, especially the recent one, IL-23, we can control the disease almost 100%, which 90 to 100% of the disease can be controlled with this drug. With the IL-17 inhibitors, which we had in India, Secukinumab, we can control the disease beyond 75% to 90%, and in a small subset of group, almost that is 20% of the patients can get 100% clearance also. Now, the IL, in the TNF alpha inhibitor is good for psoriatic arthritis. Even IL-17 can be used for psoriatic arthritis. Only patients with having inflammatory bowel disease and IL-17 cannot be used, and we either use the TNF alpha inhibitor or we use the IL.
Thank you so much, sir, for elaborating about biologics and how they make life, how they can help live life limitless. As we conclude this session, my last question to you is, how do regular doctor consultations and adhering to the therapies help live life limitless?
When the patient comes to us, we have to discuss in, in detail. First, if we take a proper history or since how long they have been prepared for the look for family history, then and make your proper diagnosis clinically. If you want to resort to biopsy or other things, you can do that. Once the diagnosis is done, you ask the patient life, what sort of life they are living, and what is the work pressure they have got. Some of them, they don't want psoriasis, not even one spot, because they are in contact with other people, like working in a hotel or like for certain jobs wherein they don't want to show anybody that they're not psoriasis. So you have to go into detail, you have to counsel them and give them the list of all the medications that are available. Also, we have got to be a little careful to check for comorbidities, because nowadays comorbidities like diabetes, hypertension, dyslipidemia, and obesity, then there can be involvement of liver, so NASH, which we call it, non-alcoholic steatohepatitis, and ask for history of smoking, ask for history of consuming alcohol. But these are very important. Ask for their uh, psychosocial history. Some people are depressed, and that share. So all this we have to go into detail. We have to ask them to change their life pattern, stop smoking, stop drinking. They've got to reduce their weight, exercise regularly, have good diet. All this is very important. And then apart from taking care of comorbidities, we have to decide which drugs can be given, either conventional drugs, or they are cheaper, or they can use biologics. We have to see whether they want associated arthritis or other problems. We have to look into that. Then accordingly, we start the therapy for the patient after carrying out relevant investigations. Certain baseline investigations are to be done, and once the investigations are done and patient is found to be fit for biologics, then we start biologics. Even for conventional drugs, certain baseline investigations are necessary. And with conventional drugs, we have to repeatedly do certain tests every month and a month, certain are to certain tests like that, once in 3 months, once in 6 months, once in a year. Very important. With biologics, the number of tests are not many. We do baseline, and thereafter, when as and when we see some side effects, or maybe at the end of 1 year, we might do.
Thank you so much for your valuable insights on the World Psoriasis Day, sir. Thank you.
Thank you.